Just a little bit about me. So I'm a consultant renal physio at King's College Hospital and an honorary senior lecturer at King's College London. I chair the UK Kidney Research Consortium Exercise and Lifestyle Group, and this is a relatively new group, and I'm quite honoured to be the only non-medic lead of one of these groups within the consortium. It's evident to the fact that this is becoming a much more researched area, and just listening in the last few days, it's very exciting, some of the new collaborations that we'll be able to take forward from this. So first of all, just a little bit of a background. So I think it's quite important to tell you a little bit about what our patients are like. So David's presentation this morning, he talked about the merit effect, and I think some of the preemptive transplanted patients are in quite good physical condition, and they come back very, very quickly. But we have quite a lot of patients who aren't quite like that. So I thought I'd tell you about our majority of our patients and what they're like. So it's recognised that kidney transplant recipients increase their level of physical activity in the years subsequent to kidney transplantation. However, we know that exercise capacity is 30% lower, and the incidence of cardiovascular disease is 4 to 6 times higher than that of the general population. And that's likely to be due to physical dysfunction, metabolic syndrome, uremic myopathy, which is complicated by end-stage renal disease and worsened by chronic exposure to dialysis, and also muscle atrophy, which is worsened by chronic exposure to corticosteroids and immunosuppression. So I talked a little bit about this in the transplant workshop, but we know that weight gain is a big problem after kidney transplantation, and despite that being a significant problem and the exercise capacity being a lot lower, routine rehabilitation for this patient group is not offered to patients, certainly in the NHS, and we feel that that's something which we need to be able to address. So there is a small body of evidence, so there are obviously some studies that we're hearing about which I haven't included in this, but there's a small body of evidence. There's small sample sizes, and unfortunately they're all of short duration, which is quite often the way new areas start out, but some of the evidence shows improvements in exercise capacity, improved baroreflex sensitivity, muscle strength, blood pressure control and bone remodeling, and also higher levels of self-reported physical functioning. However, due to the small sample sizes and also the short duration of the studies, the influence of exercise-based rehabilitation on cardiovascular disease and mortality hasn't been very well explored yet in this population. So pragmatically, we generally prescribe exercise training with aerobic training and resistance training combined, and that's to pragmatically address both cardiorespiratory fitness, but also the muscle problems which are associated with some of the things which I've already mentioned in the previous slide. However, for our study, what we wanted to do was we wanted to look at the individual effects of both of these types of training regimes before we started to look at the effects of combining them or sequencing them. And one of the reasons for this is that there's a small body of evidence, albeit in healthy young men, which shows that hypertrophy types of strength training can actually increase arterial stiffness. So we wanted to have a look at that in this population and see whether that was the case. And so our EXERT study aims and objectives, we wanted to investigate the effect of 12 weeks of either aerobic training or resistance training and compare that to usual care in our kidney transplant patients. We wanted to have a look at vascular health, cardiorespiratory fitness, muscle strength and physical function, inflammatory biomarkers, and also transplant outcomes. And one of the things we wanted to see is this something which is feasible to do in our group of patients? Would patients be willing to be recruited? Could we retain our patients in the study, and would they adhere to the exercise intervention that we were offering them? And so I designed a prospective, single-blind, randomised controlled trial. It was across 2 centres, so King's College Hospital and Guy's and St Thomas's Trust in London in the UK. We recruited 60 patients who are over the age of 18. They were more than 6 weeks but less than 12 months post-kidney transplantation, and we randomised them to aerobic training, resistance training or usual care. So these are the baseline characteristics of our population that completed the study at 12 weeks. And what you can see here, if I just pick out a few things, is our average age of our patients was 51.8 years. And you can see that there was a difference in that the usual care group was slightly younger than both our aerobic training and our resistance training group. And when looking at our time on dialysis pre-transplant, you can see that the average time was 25.6 months, and again slightly lower in the usual care group compared to the aerobic training and the resistance training group. Now, as arterial stiffness was our primary endpoint, so pulse wave velocity, and I'll explain a little bit more to you what that is before I go into the results. But we know that that age and time on dialysis can affect the vascular stiffness, so we wanted to make sure that we covaried for that in our analysis. Okay, so as I mentioned, our primary endpoint for our study was pulse wave velocity at 12 weeks. So for those of you who don't know, pulse wave velocity is a non-invasive technique to measure arterial stiffness, and it's something which is relatively easily done. It has a good inter and intra-rater reliability, and the patients really don't find it very difficult at all to have done. And the reason we chose pulse wave velocity as our primary endpoint is because of the high cardiovascular disease risk in this patient population. We also know that it's been shown to be an independent predictor of cardiovascular risk in the CKD population as a whole, but also quite recently Dale et al. Published a study, so that was last year, which showed that it's an independent predictor of cardiovascular disease risk in the kidney transplant population. So in terms of our secondary endpoints, they were mainly patient-orientated, and they were cardiorespiratory fitness, so looking at VO2 peak, physical function, looking at the sit to stand 60, and then blood pressure, resting heart rate, anthropometric measurements, so looked at weight, BMI, waist circumference, looked at muscle strength, and then for those of you who are in the workshops, we looked at the Duke's Activity Status Index. For those of you who weren't there, it's a measure of functional ability. It's weighted and it's validated in this patient population. And then we looked at the SF36 for our quality of life measure. So those participants randomized to the exercise intervention received 12 weeks of twice weekly supervised exercise and a once weekly home exercise program. The aerobic training was based on 80% of maximal heart rate, which was taken during the VO2 peak test, and that was modulated using the rate of perceived exertion scale, so that patients could work out exactly where it was that their breathlessness should be feeling, so that they could modulate that at home as well. The resistance training was quite high intensity. We did 80% of 1 RM. And again, that was delivered with a range of different multi-gym equipment and free weights. So our results were published last year in the American Journal of Kidney Disease, and I'll just talk you through some of our results. So we managed to, first of all, to recruit all of our 60 patients within 12 months. Patients were really enthusiastic. They really wanted to be a part of this. We were very keen to take all comers, and so we spoke very, very carefully with our patients, explained what was involved, and tried to get a really good sample of patients that weren't representative of just your fitter, more active type of patients. 46 participants completed the study, and what you'll see here is that we retained everybody in our usual care group, and we lost patients from our 2 intervention groups. We actually ended up with exactly the same, so 13 in each of those groups. That's been really interesting. We did do some qualitative work at the end of this study, and participants felt, certainly the participants that dropped out, felt that because of the wide geographical reach of the patient population, travelling into a supervised exercise class when they were already coming in for 3 times a week appointments was just a step too far. And also because we took patients up to 12 months, a lot of them had returned to work and felt that the timing of a supervised exercise class was difficult as well in terms of getting to that. So this is something that, you know, in designing our next study that we've taken into quite careful consideration and in our design. So looking at our results in terms of pulse wave velocity, so that's the measure of arterial stiffness, we showed using an Ancover analysis and covariing for those things which I mentioned before, so age, time on dialysis, but also your baseline measures. We showed a significant between group difference in pulse wave velocity between resistance training and usual care of -2.6 meters per second, and between aerobic training and usual care of -2.2 meters per second. So just to explain that, the clinically meaningful difference is 1 meter per second, so we quite well exceeded the mean important difference there. In terms of VO2 peak, when looking between resistance training and usual care, there was a between group difference of 2.5 mils per kg per minute, and between aerobic training and usual care of 1.8 mils per kg per minute. So again, and I know Sonsoles, she presented about her resistance training program, and when compared with other aerobic training programs, you could see the resistance training group actually achieved a better gain there, and we agree that we think it's possibly because these patients are so deconditioned that we really need to be doing some form of resistance training with them to actually get them to even be able to perform some of these tests which they have to do. So only when comparing the resistance training with the usual care group did we see a significant difference in the sit to stand 60, so that's quite a functional measure, getting up and down in a chair, the Duke's activity status score and muscle strength. It did approach significance in the aerobic training group, but we definitely saw better, more significant results with the resistance training. We didn't see any significant differences in inflammatory biomarkers or in the SF36 at that point at 12 weeks. And we think that's possibly because there's so much going on in this first year of kidney transplantation, it's possibly not sensitive enough to pick up the between group differences. Very importantly, when you're looking at these types of interventions, we didn't show any reported adverse events, cardiovascular events or hospitalizations due to our intervention. So this is just showing individual data. So this is each participant. This is a resistance training group, and at first showing baseline to 12 weeks. So you can see the dotted line is your, there you go, is your mean. So you can see that mean decrease there. When looking at the aerobic training group, again, showing that there, and then the usual care group actually showing, and a little bit controversially, showing a slight increase in arterial stiffness. And we've had loads of discussions around why that is, and I won't go into that now. So what I come on to here is actually some slides which are from Ellen O'Connor's work. So Ellen did her Masters of Research with the NIHR, and she was, I was one of Ellen's supervisors. So she had a look at the 12-month follow-up results from our study. So we're looking at a much longer term effect here, and what you can see, this is in pulse wave velocity, this is in the resistance training group, and you can see there's actually a maintenance of the, that improvement in arterial stiffness at 12 months. And once again, the same in the aerobic training group. And in the usual care group, again, there's more patients here, of course, but you're not seeing these patients come back down to that baseline level. So again, so this is Ellen's follow-up at 12 months. This is in your VO2 peak. So this is the resistance training group. And I think what's interesting to stop and talk about here is how actually low the VO2 peak scores are in this patient population, even at baseline, and how they don't actually increase to what we see as a cutoff point for survival with VO2 peak. So Kathy Setstima did a study. It was in hemodialysis patients, and she showed that there was a significant correlation between having a VO2 peak cutoff of 17.5 and survival. And here, even after 12 months, we're still not seeing our patient group up around those levels. However, what we did see was a maintenance of the improvements that were gained at 3 months. Once again, in terms of the aerobic training group. Now that was significant. There is a significant improvement at 12 months in the aerobic training group. And then the usual care group, again, very, very static and similar along that line. So it's a small sample size, and I think one of the things that we have done, which is good, is to look at this over the longer term, so we can show some slightly longer results than have been done in a lot of studies. Hopefully Ellen will publish her paper soon, and then everybody can have a little bit more of a read about that. But what we have shown is significant improvements in vascular health, cardiorespiratory fitness, muscle strength and functional ability in those patients that take part in the supervised exercise program. Importantly, although we did see a dropout in the intervention group, it's still a low dropout. It was only 22%, which is lower than the reported dropout rates in the literature. And we've shown that for those patients that live near to the hospital, it's a very feasible approach. It's very much enjoyed, but perhaps it's an approach which is a little bit one step too far if you actually live quite a distance away. So we need to be looking at other ways to engage those patients. In terms of the longer term effects, what we did show was a maintenance of pulse rate velocity with aerobic training or resistance training. So there were significant changes maintained at that stage, a maintenance of relative VO2 peak with aerobic training. And we feel, I'm banging on about motivational interviewing again, but we feel that it's the individual tailoring of our exercise program to each participant, and the use of a motivational interviewing approach and a clinically embedded team within research that has possibly promoted this sort of long-term behaviour change in our patient group. We think our findings are clinically relevant in this high cardiovascular disease risk population, and we will continue to look for ways to engage the larger population of kidney transplant recipients. So I'd just like to acknowledge our study team, so that both at King's College Hospital and at Guy's and St Thomas's Trust. And I'd just like to say that I'm doing this in memory. John Taylor was one of our transplant surgeons at Guy's and St Thomas's, who was a big fan of what we were doing and was really, really helpful, but unfortunately didn't live to see the results. So just in memory of him. Okay, thank you very much.